Hi, good afternoon, everybody, and thanks for waiting for me. And so let me give you first a lie. It's still snowing outside. It's very cold. And it's going to be like this for the next 30 minutes. Then it's going to be great. So I don't think you need to get out. So, on that note, I don't know why you didn't give me a debate this year. I was like ready for that, but so I'll try to debate myself. So, so I'll try to create some controversy, but you can help me with questions. So anyway, this is didactic in a way, and please, definitely by all means, either if it's pressing, interrupt me, or we can discuss some points at the end. But I'm going to go through some aspects very quickly and then focus on really what's hot. And I bring epidemiology only for one reason, because if you were to ask what's the best thing that ever happened in medicine the last 24 months, is this. And this is really what you need to remember. Sofosbuvir and the polymerase inhibitors like that are able to cure hepatitis C is a major impact on healthcare altogether, but also is going to have probably major impact on regard to HCC. So please remember that this is a very critical component. We don't know yet what it means in regard to HCC specific, because the expectations were that by 2026 we're going to start seeing a reduction in regard to HCC related to HCV, but now with this advent, we're wondering if this might happen a bit earlier even. However, on the other hand, there is still, unfortunately, bad news, which is that mortality from cancer, according to body mass index, is still there. If you remember, Cliff Huddis spoke quite a bit about it last year, presidential address at ASCO, that the new risk factor for cancer is actually obesity. And morbid obesity is quite associated with cancer. It's surprising to see that liver cancer, HCC specific, in male, is actually a chance of dying simply just by having a BMI more than 31. This morbidly obese, 4.35%, close to 5%. So unfortunately, this is what's guiding the picture beyond 2026. So despite all the good news I'm giving you about HCV, it seems that HCC is going to be on the rise. So what does this translate to in practice is that you're going to see more of them. We're definitely all are going to see more HCC patients, and this is already a trend that we are seeing in clinics. If you look actually in your clinics and you do a little bit of retrospective work, no doubt, regardless of what your denominator is, how many patients you see, I guarantee you have 3 out of the 10 patients you're going to see who are actually related to morbid obesity, and this is really the trend we're seeing. So with this said, I'll move on to scoring and staging. Again, kind of like few glimpses here to update you. And this is like, we like every year to kind of bring it up, because just to remind everybody that liver cancer, of course, is special. Everybody thinks their cancer that they care of is special, but this one is special because it's really 2 problems in one. There is the cancer itself and the associated cirrhosis. Not always there is cirrhosis, but most of the time there is cirrhosis. And I think probably from the discussion between Dr. Shoti and Dr. Brown, you probably guessed that as well because of selectivity for the patients. Classically, with the Charles-Pugh scoring system, you remember this is kind of like data that come from the surgical world. They try to identify who are the patients who might have a risk for varices among cirrhotics. But as you can see, there is no parameters that really pertain to the cancer itself. But we still use the Charles-Pugh simply because it's best we have at hand, and many clinical trials have used the Charles-Pugh, so it's a good reference in a way, despite its limitation that no cancer-related parameters are there, because no doubt we all agree that the cancer has a certain prognostication as well. So with this said, there has been a lot of efforts, and this is only a part of the effort that's featuring over here, in regard to different scoring and staging system for HCC that include many parameters above the red line which pertain to the cirrhosis, and many parameters below the red line which pertain to the cancer itself. And you can see the complexity of each one of them, how many parameters, wherever there's a green dot means there's a parameter you need to pull, and some of them are really parameters in subparameters, so it's quite complex. And add to the complexity which one to choose, and truly we don't know, because all of those were set in different clinical trials, in prospective, retrospective, specific population, specific ethnicities, etc. Nonetheless, we did an exercise like that, and we are not the only one who did it, but one of the exercises we did at Memorial is looking retrospectively at close about 550 patients seen by medical oncology for the question of systemic therapy. So just a very, very specific population, systemic therapy seen by medical oncology. We were able to pin it down to about 200 because this is how many parameters are required, so we had clean data. But interestingly enough, we found that some of the scoring system to really do very well, including the CLIP, which stands for the Cancer of the Liver Italian Program, followed by the QP, which is a Chinese prognostic index. Chinese University Prognostic Index. Why those? It's unclear, but the CLIP has a big plus, which is that includes portal vein thrombosis. And they probably, from the earlier discussion, you noticed that really the make it or break it in regard to cure, no cure in HCC is really the portal vein thrombosis, and probably the weight is right there. Nonetheless, another important observation on that study is that what's happening at the bottom, which is TNM staging, no surprise, it really didn't fare very well, understandably because these patients are being evaluated only by the TNM staging. We're not including any cirrhosis-related parameters, so it's understandable that it won't fare very well. But to our mere surprise, the BCLC, which was already shown a minute ago by Dr. Brown, didn't do that well. And the question is why? And I bring this up actually in putting back my most unfavorite slide, but I have to show it. So this is the Barcelona Group staging system. If anything, as you heard from Dr. Brown, she has more fancy schematics that move right and left on that, but bottom line is this is a good cheat sheet for your DMT when you sit in your board meeting. Small disease, good liver, you send to Dr. Shotty. Small disease, bad liver, you still send to Dr. Shotty for transplant, but then small disease, but locally advanced in the liver and not amenable to surgery, this is where embolization comes to place. And as you can see, the controversy was totally valid because we're not really worried about the category that are there, but what we're worried about is what's in between the categories. As you know, this coming from Barcelona. As you know, Barcelona is not in Spain, it's in Catalonia, where everything is boxed. So if things doesn't really fit into a box, it doesn't exist. So you can come with the newest therapy today, but if you don't find somewhere to fit it here, it doesn't exist. So that's really where the controversies are, and that's really one of the limitations of the Barcelona Group. But the other one, which is very important for us, is that problem right here, which somebody referred from the audience for that question, what we call the BCLCC. As you can see, this is a very big basket, and one disease, M1 disease, ECOG 0 to 2, Charles-Pugh A and B. It's really like all what we deal with as oncologists, kind of like put all in one basket. And this is really where the fine-tuning of the CLIP and the QP play part in doing that discerning of the parameters to be more specific. Actually, the good news is, at least to give credit here, after being a little bit dismissive, but now the Barcelona Group is actually working on actually subdividing that category C into probably C1, C2, and maybe even C3. So we'll just wait to take to see what this happens. I think Massimo Colombo from Milan probably say it best, is that the BCLC does very well to the left and does poorly to the right. And that's really the key message for oncologists. It's not really what you need in clinic. You need something a little bit more refined than that. So with this said, I'm jumping, of course, all the way to the category of patients with advanced disease, not amenable to a local advanced therapy, and you want to give them some systemic therapy. And the first line of treatment is straightforward. It has been there since 2007. I love my job. It's only one drug. That's all I have to worry about. So it's a randomized trial, sorafenib versus placebo, and the trial was actually conducted with the survival primary endpoint. You know that curve very well, 10.7 months for the sorafenib, 7.9 for the placebo, clinically and statistically significant. This is really the standard of care. And it's very important to put in perspective for two reasons. This is 2007, we already are in 2015, and this is still the standard of care. So it just tells you that this is quite robust, and unfortunately, while we are aspiring to move that pedestal further, we didn't really succeed yet. If anything, we're all culprit at it. Abby's here and others, and we all kind of tried to kind of like evolve that number further, but sadly, we did not succeed to doing so. And the reason is unclear, but one of the things is we definitely used the tools that we had in hand, and what did we have at hand? More anti-angiogenic therapies. and some of them are even more potent anti-angiogenic, and this kind of like poses a question is like, really, are we after anti-angiogenic therapy, or are we after something else? And this is what Alan Vinuk and I kind of like brought up as being like the ceiling of the anti-angiogenic therapy in HCC, and if really we need to move a little bit in a different direction. Well, there is one kind of last holding effort, which is based on our work from a phase 2, randomized phase 2 that we did at the same time as the sorafenib data was coming out, that randomized patients to doxorubicin plus sorafenib versus doxorubicin plus placebo. Why doxorubicin as a standard arm? Remember, this is the pre-sorafenib era, so we had to go by what was at least considered or accepted as standard of care. Patient maxed out on the dox because of potential cardiac toxicity, and to our very mere surprise, and you can focus right here in the center on the exploratory comparison in a randomized phase 2, not powered for that purpose, but at least it was planned to do an exploratory look. You can see that the median survival for the dox-sorafenib was 13.7 months, and for the dox placebo, 6.5 months. Two important conclusions here. We know what dox does. This is what has been produced before, 6 months, 6.5 months. So this is really the reference. So at least we know that we reproduce that aspect. But more importantly is, what about that 13.7? Is it real? Is it really well cared for patients, nicely selected, that really is showing a response to sorafenib and the doxorubicin fluke per se? Unclear. If anything, some biology might argue that it could be that there is synergy, and this is only 1 out of 3 items biologically that might support that. Actually, ASK1 is a molecule that floats in the cytoplasm. You throw a stressor on the cell, being chemotherapy, like anthracycline, like doxorubicin. You can pump as much as you want doxorubicin, and ASK1 is supposed to help you with apoptosis, but in liver cancer it doesn't occur because ASK1 binds with RAF, they dimerize and sit in the mitochondria. So you can throw as much dox you want, ASK1 is not there, so on vacation with RAF in the mitochondria, so it's not there. So what do? You try to inhibit RAF, and this is only for those who believe that sorafenib is an anti-RAF. For those who don't, I can talk about another theory later. But anyway, you inhibit RAF over here, and this will release the dimer. ASK1 will become readily available again, and this will lead to apoptosis. This is at least what we theorized. But how to prove it or disprove it? This is the current study that actually started under the reign of Mike Schotti when he was the head of the task force with this, and this is a very important study because it's really the first ever randomized phase 3 trial in HCC in the history of the country. And that's critical because if we don't accrue it, and this is like how simple it is, we need to accrue it to prove that we can, so we can continue getting support for that disease. But bottom line is we're randomizing doxorubicin sorafenib versus sorafenib, and that's really where this might take us. Where does the study stand at this point in time? It had only one interim analysis look, which was back in May 2013, and obviously this data was not revealed to us, but we were given the green light to move forward despite a pretty high bar in regard to improvement in PFS. We are probably about 2/3 plus of the way out. We are trying to make further efforts to enhance accrual. Some efforts are happening in Ireland. Actually, Greg Leonard in the back of the room knows about it. We're going back and forth with signatures for that. And also, we're trying to open it in the UK as well as part of some efforts. Actually, believe it or not, the UK Cancer Research got a nice $500,000 grant for that study, and we're trying to find a mechanism now how to use the money before returning to the UK government, so something to think about. But please, the most important, this study is open at no less than 350 sites in the US, so please don't tell me you don't have it available next to you. It's available everywhere, and if you really don't find a place, just call me. I can find you a place next to you, but please, we need to accrue patients on that study, very critical. And I don't think really there's too much competition in regard to that field per se in the first-line HCC. So it's interesting that within 7 years already we're talking about second-line therapy in HCC. If anything, however, the news is not yet wow. If anything, Brivnib everolimus, and ramucirumab. Unfortunately, all 3 studies have been reported as negative, no improvement in outcome. There's a bunch of other studies that's still undergoing. Actually, this one completed accrual, ADI-PEC20. Cabozantinib, tivantinib, these 2 c-MET inhibitors are still accruing. So at least one advantage to the second-line approach is that it's varied. As you can see, you have different targets. You have an FGF, you have a RAD001, which is like mTOR inhibition. You have another anti-angiogenic, you have asparaginase inhibition, you have c-MET inhibition, and this is good. The variety is important because we really need to tackle everywhere we can. And the c-MET story is the hottest item at the moment simply because of the data that was presented in ASCO 2012, 2 abstracts back-to-back in the oral session at that time, one of them giving cabozantinib as a c-MET inhibitor. Remember, this is a multi-kinase, though. Patients were all given the therapy, then they were randomized based on response. The progression of disease, of course, they were put off the study, understandably and appropriately. The patient with partial response, they continued on therapy, and the stable disease patients were randomized by what we call randomized discontinuation study to either placebo or cabo, and then looked for the outcome. We don't have yet a final story on that. If anything, it's evolving. Actually, Dr. Van Kutsem's group was quite involved in that with Dr. Verslijp. And that probably survival data is shrinking a little bit, but still pretty solid. It's not like really going down beyond anything lower than 13 or 12 months. And just to put it in perspective, what does that number mean? Remember one thing, the median survival on sorafenib is 10 months. Patients stay on the drug for 5. So 10 minus 5 is 5. So by definition, your median survival on a placebo is about 5 months, even though admittedly, this is probably better than that. It's probably about 8. And the reason we know it's 8 from some of the studies that I showed as negative, because simply better care. As you can see, we're able to talk about HCC nowadays. It means there is interest. It means patients are being referred appropriately. There's better management of the cirrhosis. So clearly, there is already some impact onto the survival of the placebo-controlled or best supportive care control group over the last 7-8 years. But nonetheless, still, if we have 12 or 13 months versus 8 in second line, that's probably news. So we'll see how this will evolve. Now, the other one was tivantinib, another also multi-kinase. Same kind of story, tivantinib randomized to placebo, the primary endpoint TTP, so they were able to cross over. They found 2 interesting findings. Number one is defined MET as a prognostic factor. MET defined as more than 50% expression in 3 to 4 plus. So really, it's very high. As you can see, these patients MET high, which are in the white color, don't do very well. Median survival is only 3.8 months. This is, by the way, no treatment. We're not talking yet about the tivantinib. And the MET low, in other words, everybody else, as you can see, median survival 9 months. Quite impressive. So this kind of like adding another target of prognostication, which translated into a therapeutic effect. Now, if you bring in the MET high patients, remember 33.9 months, and you give them tivantinib, you double it to about 7.2 months. So this is, again, is going into a randomized phase 3 study. There's a little bit of different views. The Barcelona Group is running the tivantinib study. They are only looking at the c-MET high patients, exactly as I defined it. We are running the cabozantinib one, but we're all comers. And really, the view is that probably it's a multi-kinase, so why would we, and how would we decide like who is supposed to be treated or not? So, one word only and very quickly about integrating systemic therapy with local therapy, something that Dr. Brown kind of like alluded to through some of the questions, but nonetheless, there's an argument that when you give embolization to a patient or you start an embolization, you probably are causing an angiogenic flare, and this angiogenic flare might cause certain progression or worsening of disease. So what's better than to try to prevent it from happening? The last of that data is a SPACE study, which is from Riccardo Lencioni from Pisa in Italy, and randomizing patients to TACE or TACE plus sorafenib. And this is, by the way, a very clamped sorafenib. It's like through and through, it doesn't stop at all. So really, there's a clear control of anti-angiogenesis. However, the data, as you can see here, is negative, okay? They're 3 days, but I think they're weekend, and it's long holiday weekend. So this is not really what you need to apply. And please, by all means, I would not vouch that this is a therapy you should consider at this point in time. If anything, it's not due time yet for that purpose. Last thing, where do we go from here? An effort which is happening everywhere, not necessarily only at Memorial, but we're looking at identified genes in HCC cohorts. This is only a nice representation of 48, but actually our panel at the moment has been upgraded to 420 genes, so you can multiply that by 10. And we're trying to look at patterns and see what do they mean. I have to say it's a little bit all over the place, and this is not unexpected from a little bit of a complex disease with different ethnicities, different etiologies, different risk factors. But nonetheless, we're trying to kind of pin it down further. So one of the efforts we're doing is actually collecting data from all over the world, and we're trying to concentrate different cohorts, and especially because we have clinical data from those cohorts, we probably will be able to draw some comparative work. So we have Hep B from Asia-related HCC, we have Hep C genotype 4 from Egypt, et cetera, et cetera. And the idea is to try to do that genetic sequencing and try to see if this will imply some therapeutic intervention that will maybe speed up, hopefully, the way we are trying to intervene at this point in time. So as you can see, in about 8 years or so, quite a bit happened. And I conclude to say that, remember, please, that the HCC incidence is still of concern, and this is not a exotic disease for any of us anymore. You're going to see them in clinic, you're going to see them on the rise. Scoring staging is an integral part. Please include it in your assessment and planning. Sorafenib is still the standard of care. Nothing else is justified outside of a clinical trial. Anti-angiogenic ceiling might have been reached, or maybe it's not there. Maybe we look at the new targets. Sorafenib work is still ongoing. Work second line setting is multifaceted, and I think this is a positive. And no local therapeutic roles for sorafenib yet. I add here also no role for adjuvant therapy. And lastly, molecular understanding of HCC is still underway, but hopefully it can shed some light on some answers. So I'll stop here. Question, thank you.
Great, thanks.